Hi, everyone. I'm happy to introduce today in our audience and for our community, Robert Kelly, Dr. Robert Kelly, very smart person and very successful manager in terms of business. And right now he's a consultant cardiology and lifestyle medicine. And today we are going to talk about heart attack problem, how this related to the current situation with COVID, what will be in the future, and other aspects of all this problem related to the heart disease. Dr. Robert, once again, thank you so much. And you can introduce for our community, just for the context, we're going to share this video with the people, with the companies who will be, who will want to change situation with the mortality rate of the by different heart disease. Please
Sure.
introduce yourself if I introduce you a little bit.
No, you're fine. Thank you, Alex. So my name is Robert Kelly. I am a cardiologist and lifestyle medicine physician. I am based in private practice in Ireland. I trained as a cardiologist in the US and North Carolina in the early 2000s. I have acquired an interest in lifestyle medicine in the last 10 years as a way to try and transform cardiology patient and heart health patients. And I've also set up a coaching business more recently where I actually coach patients, which is a fantastic insight for cardiologists. But at the same time, I'm an interventional cardiologist. I treat all types of patients, heart attacks included. I put stents in patients. One of the things that's of interest to the conversation is when I was in North Carolina as a fellow, and then as an attending, I was part of the group that set up the rapid access program for the management of acute myocardial infarction patients in the whole state of North Carolina. So it's something that's very familiar to me. That was almost 15 years ago. I hope it's changed since then, but let's see how the conversation unfolds.
Thank you, Robert. And you have a unique combination of cardiology experience and knowledge and practitioner, your consultation practice and things to help people with heart disease. But before we start deep dive to the heart attack problem and other things, could you share some thoughts about yourself and how did you choose the medicine area and how it was in the beginning of your career?
So I am the eldest son of a retired, now deceased consultant urologist. So that's Men's Health Waterworks. So my dad died in February of this year at the age of 88, having retired from practice at the age of 87. My mother is a retired ophthalmologist, so she's an eye surgeon. And I'm one of 4 children. I am the eldest. I graduated medical school in 1992. And very sadly in my life, my brother, who's a year younger than me, died of sudden cardiac death the year behind me when I was in final med. And that was 30 years ago this week. So I probably ended up as a cardiologist as a consequence of my brother's unfortunate sudden death, or at least it had some relevance to that. I have 2 other siblings. One is also an ophthalmologist, and the other one works in IT. So I don't know who's the smart member of the family. We let other people make those decisions. So, part of this that I got into medicine was family-based. I was very familiar with it. Part of my choosing to go down the cardiology route was personal. And, I've always had a passion from it from the minute I've been in there. And the passion has got bigger and bigger as a consequence of really exploring greater opportunities that have come my way.
Awesome. In other words, first of all, you are from the family where everyone has a very high experience in education and in different area of the medicine. On the other hand, you have some personal think and personal attention to this problem because you inspired by this some tragic things, right?
Yes.
Okay, and why did you choose Royal College of Surgeons in Ireland? And could you share some
So,
what was your choice, if it was? And yeah.
So when you want to go to university in Ireland, you go through the equivalent of high school, but you don't have to do a basic degree when you leave high school. You go through a state national exam. You have to reach a certain criteria, and then you get offered a place in medical school. And so in a country of approximately 5 million people, there are 4 medical schools. There are 5 medical schools. There are 3 medical schools based in Dublin. There's a medical school based in Cork, there's a medical school based in Galway, and there's actually another medical school recently based in Limerick. So each of those medical schools will offer approximately 40 places to Irish people like I. So that's 240 medical school places. However, each of those medical schools also offers a couple of hundred places to people who come from outside Ireland and who want to pay for their private education as doctors overseas. They still have to do entry exams to get into them. So in Dublin, there's the Royal College of Surgeons, which has now become a university of its own. There's the University College Dublin, and there's Trinity College Dublin, and they all have their own histories. But the Royal College of Surgeons is probably the place that I suspect that the fun factor and the party life might have been better known for the College of Surgeons than the other places. But the College of Surgeons has an extremely strong tradition with surgical practice around the world. It's a little bit like the Harvards and the Stanfords of this world. They have very large footprints all over the world. They partner with a lot of medical schools, particularly in Malaysia, but also in the Middle East. They also do have a huge amount of different groups of graduates who work around the world. So the College of Surgeons for me had a very good footprint. My father actually taught in the College of Surgeons. Myself and my brother and my sister, all 3 of us went to the College of Surgeons as medical schools. And I actually am on the teaching faculty now in the College of Surgeons, where I teach in lifestyle medicine and I teach in positive psychology. So it's kind of a tradition that's grown and grown. But the medical schools are very similar in what you graduate as. They're very similar in terms of how the program works. You go into a hospital after you qualify. And the medical school program is 6 years, unlike the US, where it's 3 to 4 years. So for example, when I did my fellowship, I was much older than most of the fellows were. So that's why I ended up in the College of Surgeons.
Got it. In other words, Royal College of Surgeons in Ireland, it's not like a local institute or academia. This is a organization which collaborate with the different institutes around the world. And if you join to this,
it's actually it is a medical school. It's now called the Royal College of Surgeons Health and University of Health Sciences. So it was affiliated with one of the other medical schools through its parent. So the National University of Ireland awards degrees. The College of Surgeons is one of those medical schools. So it has its own medical school. It also has a huge dedicated medical and surgical postgraduate sets of programs. Now it has a school of nursing, it has a school of pharmacy, it has a school of physio, it has a school of undergraduate medicine, you name it, it has everything. Whereas the other universities offer the same as the Harvards and the Stanfords. They offer all these other degrees like arts, computer science, engineering, veterinary, whatever else it is. So that's the real difference between the 2 of them, or the 3 of them.
I got it. Thank you so much. And could you share your time during studying at Harvard Medical School, how it was, and some insights?
So I'll tell you, you posed a question that I'm an interesting person if you look me up on social media. So I'll take you on a little journey to where I am now. So I'm now in my early 50s. So I graduated medical school in 1992. I did my basic training in Ireland. The cardiology training program fellowship is approximately 6 years. In the middle of that, went and did a PhD in the UK in the University of Dundee in clinical pharmacology. Then I came back to Ireland. Then I went to America, did a fellowship in the University of North Carolina in Chapel Hill. I became an attending assistant professor in North Carolina for a few years. And in 2007, I came back to Ireland. Now, along the way, short of coming back to Ireland, I did one module of the UNC Business School's MBA program, which was on leadership, which was offered to newly appointed attendees. I did that for 3 months and I said, wow, MBA, this is great fun. I'd love to do this. So I was due to return to Ireland. I found it was a very expensive thing to do in America. So I came back to Ireland and I found an MBA program that was based through the University of Henley Business School in England. And I managed to do their MBA executive program over a 3-year period by distance learning. And I got very involved in technology at that time and disruptive innovation, because that was what was happening at that time. There was a guy called Clayton Christensen, who was based in Harvard, who unfortunately died last year, who was hugely involved in the whole principles around disruptive innovation, about urgent care clinics, and about the way healthcare could be offered. So I got very influenced by that. I actually spent some time in Boston with him. And then as my health career evolved, working as a consultant in Ireland, I became very interested in lifestyle medicine after I dealt with some stress in my own job, and was introduced to a number of different key players on the East Coast of America and on the West Coast. And so in Harvard, I attended their lifestyle medicine program and was certified off that. And I also attended their mind-body medicine program, which is really fascinating, learning about your stress, learning about stress management. And so I spent some time there. I also actually have subsequently, in the last year or two, become a tiny habits coach, which is based on a gentleman called BJ Fogg, who's based out of the Stanford Group in the West Coast of America. So, and I currently work with one of his team who's based in Texas. So I have a very large, I have a good footprint in America, and I have a very, very, I really enjoy that. But the other thing to share with you is I'm involved as both an investor and as an advisor for a health tech company in the US called Fruit Street Health. And Fruit Street Health run a diabetes prevention program online where people are helped to prevent diabetes or manage weight. They've broken into the COVID market as well, and primary care online services, very like a lot of their competitors. But that company has 256 doctors who are the investors. And so I have 256 physicians / surgical friends all over North America, all of us who corroborate together to decide how the diabetes prevention should be run across that country, who also have a huge input of all our specialties, and who also have had an opportunity to share everything that goes on, share all the technology. So it's been a fascinating experience to be involved in something like that. So you could say I'm probably in every state in America at this stage.
Yeah, thank you so much. It's a very amazing that you have all connection in different states, and you work in different states, Texas, North Carolina, and others. And speaking of this, does the medical system in Ireland a little bit different than in United States from your point of view? And what the major point?
So the major difference between the two systems are the way the healthcare is paid for. So in Ireland, we have a system where about half the population get free healthcare, and they all get free healthcare. You don't have to have any level of insurance to get access to a hospital. I remember when I worked in North Carolina, where UNC's hospital in Chapel Hill is a state hospital. So what I thought was a public meant it was free to everybody. But then I realized that that's not the case, that certain members of the population don't get any access to healthcare, whereas in Ireland, everybody gets access to healthcare. However, however, the supply of healthcare is limited. So there isn't a bed for 5 million people, and there isn't a bed for everybody. And so you have significant waiting lists. So of a population of 5 million people, approximately 1 million people are on a waiting list to see a doctor or have a procedure in this country at the moment. COVID has a big bearing. It's taken out a lot of the beds. We also have a private health system, which I work in exclusively, which has about 50% of the population attending that system. And those people pay from their own pockets. Some people have support from their companies, but most of the companies do not pay for it. So it's self-funded by an insurance model. In the US, the model is very different because your employer tends to pay for your health, and you tend to make some contribution depending on the level you work for. And therefore, the systems are very different that way. The irony when you come to lifestyle medicine, as an example, is if I want to try and encourage people to improve their health behavior, or if I want to encourage people to make changes in their life, their employer doesn't necessarily have any responsibility for it because the employer is not paying for their health. They're paying for their health. So it's a very interesting, different dynamic. The other challenge in Ireland is, like the US, the cost of healthcare, as Irish people think, is quite expensive. However, the cost of private health insurance in America per month is probably about 10 times what it is in Ireland. So, you get a better access, you get a more expensive system. The dynamic works differently. And that was when I worked in America, I was very aware of that because I paid a contribution monthly from my salary for healthcare. My wife and I had 2 children born in America. The experience was fascinating, but it was extremely good. And it was interesting how you pay additionally for part of your medication, part of your clinic visits. In Ireland, you pay for your medication. Everybody pays for your medication unless you have certain illnesses. So there are certain chronic diseases where the medication is paid for. And then, like what's happening in the rest of the world at this moment in time, I read last week about the 500,000 healthcare workers leaving the US health system. I've read about the cardiology shortage that's coming, the shortage of heart surgeons. In Ireland, we're in exactly the same problem. We have a number of healthcare professions have left the system. We have a number of nurses who worked in the system part-time who've decided it's not worth it anymore for what they have to go through. We have a huge shortage of nurses to come in at that level. Ireland has a very large migrant population that's come in from different parts of Europe and Asia. A lot of them have gone home. And a number of people also in terms of the medical professional side want to go and train abroad. And the reality is that the impact of finance more than anything else is because there's going to be a huge demand for doctors in the US. All those Irish people go to America because they'll be better paid than they will in Ireland. So, and it'll be like it was in the early 1980s and the late 1970s when exactly the same thing happened for a different reason. So, you know, our health system's going to struggle a lot with long waiting times, with a short resource of nurses and doctors in particular, and dealing with what COVID's going to leave behind, like it is with every other health system, in terms of being able to manage patients. But the big opportunity for people like me is that the well is never going to dry up in terms of the people I'm going to have to treat. It's just not going to go away. And furthermore, the impacts of COVID, which I'm now going to talk about in a short while, it's going to leave an awful lot of disease in the system that's new as well. So, you know, the opportunities in the health system as a business entrepreneur head of mine are enormous. The busyness in terms of the amount of work I have are also enormous. So, you know, it's an interesting time in healthcare, particularly as much in this country as it is in yours.
Okay, and what do you think in terms of from insurance point of view, probably from the medical point of view, how to handle situation in Ireland, in United States? Try to imagine that you are, I don't know, president of the world or somebody who has a lot of resources, human resources, financial, whatever. And how you will try to solve this problem?
So when
I mean, lack of the, as I realized, lack of the cardiologists, because some of them migrated from the Ireland to the United States because they have a more better financial situation. Some cases in terms of insurance, when your employer work, pay for your contribution and all this stuff related to this, and the long wait list in Ireland when you actually have a 1 million people behind you to have a surgery.
So the interesting thing is, you know, if it was a perfect world, one of the major challenges in Ireland, and I suspect it's the exact same in the US, is that bureaucracy and inefficiency and red tape destroy absolutely everything. And health is a prime example of how it happens. And so there are certain centers of excellence in the US that run extraordinarily well, and there are other places that struggle. And much of the kind of academic medical institutions in the US struggle, so they buy the private practices because the private practices are struggling because of cost and financial issues. In Ireland, the challenge is the opposite. The public health system is run very inefficiently. It wastes a lot of money, and there is no accountability factors in place to identify where the money is going, how effective the turnover is in terms of throughput of patients, lengths of stay, et cetera, et cetera. And it's not aligned with any clear vision. And so, you know, it gets managed in political cycles. So in a public health system, what happens is the government lasts for 4 years. At the end of 4 years, a different government comes in and they change the focus. Or alternatively, what also happens is because of the current times we live in, obviously the COVID factor gets in a way and disrupts everything and takes all the money. But there's been no joined up thinking in terms of trying to make the system better. There's a big initiative at the moment called Sláinte Care in Ireland. It's an attempt to nationalize the system. There is no effort whatsoever in terms of how that would be funded. There is no way it can happen with no doctors. There is no way it can happen with no nurses. And there is a certain sense that you can't pay for anything, which is a political opinion, when the reality is it would probably work best if it was more transparent, if people work together, if the system was allowed to pay to get rid of some of the waiting list, but it needs the efficiency. The system will always be as bad as it currently is without the infrastructure and the efficiency in place. And so I think, all the money in Ireland will not solve the health problem. It doesn't take all the money. It takes an entirely different group of people to be allowed to exercise what is sensible and reasonable targeted outcomes, and use the data in truth to drive the outcomes. Unfortunately, a lot of people in Ireland would joke to say, well, could you identify the most successful businessman? So a name in the past has been a gentleman who runs a very efficient budget airline in Ireland. Somebody says, could you not stick him in running the hospitals, because he'd be much more efficient? And it's not about the cost. It's about the process. It's about the systems. And it's just about the fact that they're just full of red tape. And one of the interesting stories I share with you was when I left North Carolina back in 2007, my boss at that time, who had trained and worked in Ireland, said to me, well, you know what, Robert, don't expect the system in Ireland to change that much from a health delivery point of view when you go back. And don't expect it to change much in your lifetime. And so my natural response to that was, no, you're completely wrong. You haven't been here. I'll take my chances and see what I can do. But he's absolutely true. So it's, I said to somebody during the week, it's like moving the deck chairs around the Titanic. So, I mean, the point to it and all that is that nothing actually happens. So in the US, I'm not really in a position to say where the health care system is at this time, because I haven't worked there for some time. But I mean, I do think that everybody has to factor in everybody else and all the stakeholders that are involved. Inflation and the realistic cost of health is very expensive, and that's driven by lots of different factors. But I also think that ultimately trying to center everything around the patient is where it should be, and not around the hospital, and not around pharma, and not around industry. It should be about making people better. And I do firmly believe, as a consequence of where I've gone through my career in the last number of years, that the only way to deal with the healthcare system is to stop people getting sick. And ultimately, it is about prevention. And even though I'm an interventional cardiologist, patients keep coming back needing more procedures because they do not change their behavior. And ultimately, that might be great in the financial return for some hospitals, but it's not great in the performance of the population and what you can do for people, nor is it great for their lives. The challenge is patients don't understand that.
Got it. And keyword from your whole thoughts, this is first of all, efficiency, right? And the efficiency in terms of big organization like medical, maybe industry on the level of the country, and probably the private practice, private business or commercial business will help with this, because usually, business is more efficient than
absolutely. But the problem, Alex, in Ireland is that it's very political. And so one side of the government is very against the idea of having private healthcare, that you should have to pay for it at all. The problem is that the system is too broken to turn around and make that the way the system should work. So you just now put every member of the population in a broken system. That'll give you 5 million people on a waiting list. So, and there are certain expectations within that proposal that are totally unrealistic. So the system is not likely to change until somebody comes along and says, well, you know what, you really need to sit down. But what happens then is that the process of government gets in the way, politics gets in the way, and nothing happens. And this has been there for decades in this country. And it is the same in a lot of other countries around the world. So it's, it's very frustrating. It's very disappointing if you're a patient. And one of the ironies, if you're a doctor, is you always have to face into the idea that at some stage you yourself will become a patient, and who's going to look after you. So it is frustrating, but as I said, if you focus yourself around the patients and forget about the system and do your best by the patients, that's really what matters.
Yeah. And the second interesting thoughts from you, that instead of trying to fix the problem when this problem came, instead of this, it's more easy and more better to invest time for prevention this, and don't seek at all. And this much more easier to achieve than trying to fix after that with a high cost and all this waiting list and another factors. Of which,
the only way you're going to cure anything is preventing it happening in the first place. I listened in on a talk last weekend about where heart failure treatment is going at the moment. So if you're somebody out there who's never had heart failure before, in the next 5 years, the standard of care is going to be 15 tablets to be taken every single day of the week for the rest of your life. I mean, so I mean, I think that's worth giving up the cigarettes and getting your blood pressure sorted out and losing weight and taking the exercise personally, unless you want to be that person. And add to that, forget about the tablets, your quality of life and everything else is destroyed. The same is true that you can prevent a lot of cancers, you can prevent a lot of mental health, you can prevent a lot of heart disease, and you can prevent heart attacks. The reality is the challenge is trying to get people to change their behavior. That's what I've become very interested in recently. Because if you can do that, people won't need to go into a hospital. People won't need to see doctors. People won't need the services that cost all the money, because people will learn that it's more important to look after themselves. But how you set the system up that way is a different challenge. And again, there's political. I mean, insurance companies in Ireland, unlike the US, do not encourage you to be healthier, because the health premiums cost the exact same whether you're healthy or whether you're unhealthy. So it's a real perverse irony in that respect.
Got it. And it's very logical that after all which you shared, you started working more involved in the business, and you're trying to change this lifestyle habits, behaviors, and trying to really fix this problem instead of I don't know, try to involve in political world, or maybe to invest some time in medicine. And could you share your business experience in cardiology, and what is this, and what the difference when you are in position of the doctor and you're working for the government, and when you're working as a businessman, as an entrepreneur?
Okay. So I actually work for myself. I'm self-employed. So I'm paid per patient or paid per procedure. That's the way the insurance model works. Or I charge patients to see me for a consultation fee in my clinic. And I also get paid to report procedures like heart scans and CAT scans and ultrasounds of patients' hearts. And that's how my private practice model works. Then I have some staff who work for me, and the hospital provides access to their facility free of charge, but they get a large percentage of the procedures that are undertaken within their building. So my business as my practice is that. Now, I have interests, as I've said, in lifestyle medicine. So I run a health coaching business, which is separate, which I actually largely do myself. I have an IT person who works part-time with me. In my earlier interest, when I found myself coming into lifestyle medicine, I got very interested in nutrition. And I still am very interested in nutrition and functional medicine and nutrition. And so I hired a nutritionist, and the two of us set up a separate business to help people manage nutrition around functional medicine and lifestyle medicine. So I run that separately as a company with her as a business. So I have that business, I have my coaching business, I have my cardiology practice, and then I do some consulting and I do some advisory stuff, and that sits on top of my cardiology business, even though it's not cardiology. So it works out that way. I also advise companies. I'm the chief medical officer for a remote patient monitoring company in Switzerland. That's called VTULS, VTULS. I'm also involved as an advisor in a number of structural heart companies around the world, which are based in Asia and in Europe. And the Fruit Street Health I mentioned already. And I have been involved in companies that have failed before, involved with a telemedicine company many, many years ago, which didn't succeed for different reasons. But again, as Alex has said about my interest in changing health for people around the world, I got involved in telemedicine. That was almost 10 years ago, in a very different climate to what it is now, but largely to try and give something to patients in the community, because community care in Ireland is missing. You know, you rely very heavily on a hospital to treat you. The primary care doctors are so busy, particularly even at the minute, just trying to triage COVID patients, that when you leave hospital, there's nobody there to look after you. Nobody at all. You know, and even the system is so stretched the minute you can wait 2 or 3 months to get your prescription refilled. So, you know, the telemedicine links and some of the technology has always been a very interest to me to see if there was a better way or a way to give more value to the patients I look after. And so the nutrition came out of that, probably out of personal reasons, trying to lose weight myself, and also identifying that nobody was doing that. Nobody does that anyway as doctors. And also the approach around coaching was much more attractive because you get patients to change. Whereas if you give patients lists of food, they couldn't care less, they throw it in the bin. So, you know, there's there's all those dynamics. But in truth, I'm a cardiologist. My health coaching is coaching people to improve their heart health, which is the same as every other health. And my consulting is all cardiology related. My teaching is all cardiology related, and everything else. So it's effectively one business. It's a business. It's like a wheel. It's a central cardiology business that has an awful lot of other aspects to it. And one of my friends jokes to me that, Robert, I'm more like a business doctor than I am like a just doctor. So I
got it.
and it works, and I've managed. It's taken a long time, by the way, just to try and bring it and center it, bring it all to the middle. So because you might say, where do I find all the time for doing these things? But I do manage, and I realize how things get bigger, that I add to that, I recruit people, and I do things that way. So hopefully that part will happen soon.
Thank you. It's incredible. And my next question will be, because you has a great experience of the working in Ireland, in United States. Why do some countries less struggle with heart attack problems, some more? And what the difference, what the key things from this? Yeah.
Well, so I think that if you take the physical health bit first, okay, so the traditional risk factors for heart attacks would be smoking, high blood pressure, diabetes, cholesterol, body weight or overweight, that group, and you'd add in a family history. So, the vast majority of inequality when it comes to that is that certain parts of the Western world have the bad diet. A lot of them smoke. There's a lot of inactivity, and those just add to diabetes. The other major risk factor that's come in, and it will come in even more with the effects of COVID, is the relationship between stress and heart disease. So, stress has been proven in the last couple of years to be an independent risk factor for heart attacks. So, just because you smoke and are overweight because you think you're stressed out, I'm afraid that means you have 3 risk factors for heart disease. It's not that you have stress and that's causing the other problems. So these aspects of care people don't necessarily realize. In the guidelines in this part of the world for cardiology, more recently, mental health has really come to the surface as a significant independent risk factor. So it's independent of whether you have blood pressure and everything else. So it really does load the gun in terms of the risk for heart attack. So that aspect of the Western world is very obvious. There are other parts of the world, like Africa, where there were countries that have no heart disease until certain large takeaway organizations, fast foods, fizzy drinks, and cigarette companies have managed to set up outposts around those countries for different reasons. And then everybody gets drawn to the same habits that we all have in the rest of the world. And you've got to factor in as well other aspects of life. And you've got to consider heart disease in terms of heart failure from infectious diseases in other parts of the world. You've got to consider poverty. You've got to consider food. So the risk factors vary. In your own country, there's different parts of the population that get more heart disease. You have a lot of Hispanics who traditionally get a higher cholesterol level. You have a lot of African Americans who have a huge amount of hypertension. But you have an inequality, and you have a trouble with the system itself in terms of people accessing the next line of treatment, or understanding or being educated of what the problem is, or knowing what to do about it, or having people to help them do something about it. So, where smoking was big 20 years ago and may have decreased, weight is now a big problem. Diabetes is a big problem. Hypertension is a big problem. The stroke levels go up, the heart attack levels go up. And at the same time, the systems and the complexity and the bureaucracy only get more and more and more and more and more. And so we're kind of shooting ourselves in the foot all the time.
Got it. Thank you so much for this. Sharon. Actually, we're on time. And Dr. Robert, do you have 30 minutes more, or we finish?
Yeah, no, that's fine. You're good. Yeah.
Okay. Because in the second part of our interview, I want to discuss more business and technology aspects of this, and I'm sure this will be very interesting. And when this record will finish, feel free to use the same link, and we will proceed our second part.
Yeah.
Thank you. And my next question: what do you think will be in the future with the heart attack problems? From your perspective?
So I think the challenge with heart attacks problems in the future is going to be the age is going to get younger, which is a big problem. And I think the age is going to get younger because I think that the impact of COVID and the impact of COVID on stress and mental health is a big challenge. And I think that group of people will start presenting in 10 years' time with heart attacks. And it's not that they've all been at home eating the wrong food or that they've all started smoking. It's the independent risk associated with mental health and stress. I think that the rest of the situation will probably remain the same. We've improved outcomes because we can get people to treatment much quicker. But I've said earlier, I mean, the best way to improve outcomes is to get people to stop smoking, is to get people exercising, it's to deal with a lot of the inequalities. It's also to deal with the hypertensions and everything else in society. And it's also to get everybody kind of more health engaged. One of my biggest challenges at this moment in time is to try and help people actually understand what the word health means. Because the vast majority of people, if you ask them, and they're very well educated people, including some of my close friends, what do you value most in life? And health does not feature on the list at all. And you probe people and say, well, what about this? What about that? And health is nowhere near it. And then you kind of say, well, I'm a doctor. Does that help you put anything on your list? And you go, oh yeah, my health is kind of important. But a lot of people go, sure, it'll never happen to me. I wait. And then your friend drops dead, or you drop dead, or you don't think about those things. So as long as health is seen as kind of something that's not important, then you can't expect anybody to do anything about it. And so my challenge is trying to understand why that is, and whether it's not about giving people lots of information, because people don't retain that. And it's not about kind of billboards and loading people with science, because they don't retain it either. So that's why I got into all the behavior change, to try and genuinely help people change their behaviors. But you know, it's very complex. It takes a lot of effort. And there really is an awful lot of work that will impact the future risk around heart attacks. So there's still an awful lot of work to be done.
Okay, thank you so much. And we smoothly jump to the second part of our interview. And let's rejoin by the same link and see you.